Good morning, everyone, and welcome to today's webinar presentation, Health Equity, Awareness, Advocacy, and Action in Family Home Visiting. My name is Sarah Carsley. I'm an Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin the presentation, I would like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I'm in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I would like to acknowledge Daniel Coles, who helped co-author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio-video has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today's session, Dr. Susan Jack. Dr. Jack is a professor in the School of Nursing at McMaster University. As a leader in public health nursing practice, education, and research, her work focuses on the development and evaluation of interventions to improve maternal, infant, and family health outcomes. As the lead of the Public Health Nursing Practice Research and Education Program, she is committed to advancing public health nursing practice and education. Over to you, Sue.
Great. Good morning, everyone. Thank you, Sarah. As always, I'm so excited to join everyone on these Wednesday mornings, and happy to be co-moderating with Sarah and representing the work of the PHN prep team in supporting public health nurses, supervisors, managers, home visiting staff in their work with families, as well as all of our other friends and colleagues from across North America, across the globe, who work with pregnant individuals and families with young children. Welcome to today. Now, it's truly my genuine pleasure to introduce our speaker for today's presentation, Dr. Melinda Forsyth-Carmouche. And Dr. Carmouche is a healthcare educator and a consultant with over 20 years of experience in nursing education and 34 years of professional nursing experience in maternal child health, family health, and public health nursing. And for the last 7 years, she has provided consultation support for registered nurses and program administrators implementing the home visiting program model called Nurse Family Partnership. And Melinda has worked professionally as a labor and delivery nurse. She herself has been a home visitor. She's been a legal nurse consultant, nursing professor, and as a leader of a nursing program. And her greatest successes are personal ones, in addition to all these amazing professional accomplishments. She's been married for 31 years and has 2 adult children. So Melinda, welcome. We're so pleased that you are able to share your expertise with us. And I pass it to you, Melinda.
Thank you so much, Susan. And I will say, rather than say adults, I should have put adulting, because they're in the process of adulting as far as my 2 children. So good morning, healthcare practitioners and home visitors. I welcome you this morning to this session of Health Equity, Awareness, Advocacy, and Action in Home Visiting, in Family Home Visiting. And as Susan said, I'm Dr. Melinda Forsyth-Carmouche. And so let's get started. So the learning outcomes for today, in this session, we're aiming to deepen our expertise in the crucial areas that relate to health equity. So we're going to describe the concepts of health equity as well as health inequity. its relevance to health outcomes in the context of home visitation. We want to also recognize disparities faced by Indigenous and Black persons as they relate to access to culturally appropriate care within community-based settings, including home visiting. Lastly, we want to identify reflective practice strategies to support supervisors and registered nurses or health professionals as they engage in critical conversations with public health nurses or other community partners who advocate for women, birthing persons, children, and their families in home visiting settings. So that's our goal for today. So I want to start off by just us setting our intention for today. And so I thought of two key words that I wanted us to focus on as we set our intention. One is authenticity. In this space, we don't want to check our biases. You've often heard that said, right? Check your biases at the door. Instead, we want to invite them into the table or into the room. We can't address what we don't acknowledge. So it's important to bring your biases with you into this session. The second term that I wanted to focus on as just a focus word is acceptance. This space is officially declared a non-judgmental zone. Our lives and experiences are different. We're going to have different perspectives. We won't always agree with someone else's perspective, but we can respect those perspectives. So that's our goal here today. And I just want to take maybe 10 seconds and just kind of focus on those two terms to set our intention. All righty. And I also want to say, just while mentioning that there may be times where in this conversation, you may feel triggered by something that's being discussed, and feel free to turn your camera off, walk away, whatever you need to do to kind of mindfully self-regulate. So feel free to do that at any point in the session. So I want to start just by talking about the concept of the melting pot and the mixed salad to kind of set the tone for the things that we're going to discuss. When you think of a melting pot, what you think of is that as you see in the image, you see a lot of different ingredients that go into one pot, and then they melt to all become the same thing, right? And that's basically assimilation. And so when we look at the historical context for both Indigenous populations and Black populations, what we know is that as they migrated to America, Canada, what happened was they to some degree assimilated or were encouraged to assimilate to be able to get opportunity. So that's similar to the melting pot. I personally have never really embraced that term just because I like individuality and uniquities. And so I always like the concept of it being a mixed salad, because when you make yourself a really good salad, what happens? You put in all these different ingredients, all the things you love: lettuce, tomatoes, cucumbers, celery, meat or seafood, whichever things you like, you put in that salad. And what happens is that when you mix the individuality together, everything is enhanced. So the flavors are enhanced. It's not the same as eating lettuce by itself, right? It's much more flavorful because you have diversity in that bowl. And so I like to use that just as a concept of what our goal is in public health and in nursing and in healthcare. Our goal is to show not just tolerance, because to tolerate someone means that you're just barely accepting them, right? We want to go beyond tolerance to appreciation. So we want to really appreciate the individuality of each individual. You know, all the unique things that they bring to the table or to the salad make it more flavorful. So embracing that diversity instead of kind of shying away from it. So this is a self-assessment, because you always want to start right with self-reflection and to just kind of reflect on what are my lived experiences, what is my past, what has my past advised me that is impacting my present and could impact my future. And so there are several assessment tools. This is just 3. Project Implicit has multiple tools where you can assess different types of racial or ethnic groups or sexual identity components to see if you have biases. whether they're explicit or implicit biases. So it's a good way to do a self-assessment just to see where you are. And then Black Lives Matter, the survey that's there is just basically assessing to see, do you agree with the movement or the initiatives of the Black Lives Matter movement? And then white fragility just talks about like the how individuals of Anglo descent may feel triggered when they hear certain content, or even when they're confronted with certain issues. And so just dealing with what's the background, what causes that, and how do I adjust to it, or how do I survive in it, right? And so those are 3 different self-assessments that you can utilize to kind of just do a self-assessment to see where you're at. I encourage everyone to do that, because we know as health professionals, we've been charged with providing culturally appropriate care, right? And we're doing that to protect health outcomes. And so make sure that you do some type of self-assessment to just kind of set the tone for where you're at and to determine where you want to go. And then I love this schematic or graph or diagram, because it gives you a good idea. And this comes from the learning model. That's the roots of it. It was used a lot during COVID, where they showed, with everybody having such fear about COVID, they used the same kind of diagram for that. And then someone adapted it for anti-racism. And so if you look at the 3 different zones, there's the fear zone, the learning zone, and the growth zone. And if you identify the statements that you typically make, it will give you an idea of where you're at in the becoming anti-racist process. All of us have some degree of racism, right? Or some kind of attitudes or beliefs or biases, whether they're implicit or explicit, that kind of advise or influence how we treat individuals. And it's important for us to embrace that first, so that we can identify for different race providers and their survival rate based on the provider that cared for them. And that's just one example. You have similar studies that have been done in maternal health as well that show similarities. So we want to make sure that we're always being connected to the data that drives our practice, and being aware of those trends, that because you can't argue to edit or adapt our practice to protect vulnerable families. And so I also have a quote here that just basically says, the beauty of anti-racism is that you don't have to pretend to be free of racism to be anti-racist. Anti-racism is the commitment to fight racism wherever you find it, including in yourself. And so that's basically just conceptualizes the whole diagram of and our goal, right? That's our goal, to be anti-racist, because we know that racism influences health outcomes. So I want to talk a little bit about, and I'm trying to follow my speaker notes here. So I want to explore just the intricate relationship between the social determinants of health and health equity and inequity in the context of healthcare for both Indigenous and Black persons, primarily focusing on the maternal child care in Canada and America. So as we do that, there are a couple things that are important for us to understand and address as it relates to health inequities. One is cultural competency training. It's very important for individuals to become culturally trained. As health professionals, I know I'm a registered nurse, so in nursing school, we were taught, like, here are some of the generalizations that you'll see in different cultural groups. And this kind of is going into the next slide a little bit too, but what ends up happening is that those are generalizations. So we get that information for what reason? We're given that information because we want to use it in our practice. Like, for instance, if I am caring for a individual that is a Black teenager, right, that first pregnancy, I know that that individual is predisposed to pregnancy-induced hypertension. So I use that information to advise my nursing actions, right? My assessment. It means that that individual I'm going to check her blood pressure more frequently. I'm going to check her for swelling, mostly generalized swelling. I'm going to check her hands, her face, those type of things. I'm going to keep an eye on her blood pressure, not just the blood pressure that she's presenting with now, but I want to know the historical blood pressure. Where did she begin? Where is she at now? Because we all know that a lot of times with pregnancy-induced hypertension, you can get an individual who is actually seeming normotensive, but it's actually hypertensive for them. So in addition to the 140, 150 over 90 that we typically look at, you also want to look at the rise in the diastolic and systolic blood pressure. So with this individual, a lot of times some teens have low blood pressure. So you want to make sure, like if that baseline was 80 over 50, you want to see if they're gone. If they're 130 over 80, that's hypertensive for them. So that individual, I'm going to watch a whole lot closer because I know her predispositions, right? But where that becomes problematic is if I then take that information and use it and weaponize it against the client and start identifying, like the comments that you may hear people make could be, well, I don't know why that person keeps getting pregnant or why this is happening when they know they're predisposed to this. So we use it to advise us or inform us, but we don't use it to weaponize it against patients or families. So that's real important to remember. So cultural competency training is important. And likewise with, if it was a white American or white Canadian, then we want to also know that they're predisposed to another sequel of pregnancy-induced hypertension, right, which is HELP syndrome. So we know that if they're 35, Caucasian, 35 and older and Caucasian, they're predisposed to that. So we're watching them like for abnormal bleeding. We're watching them for signs of preeclampsia. We're watching them for like petechiae, easy bruising. We're also making sure that we're advocating that they get the right labs. So that cultural information advises our practice. It gives us valuable information to walk into a situation and know which things I need to be alert for. So that's the importance of it. So that's cultural competency training. Another one is community engagement. You have to, in order to engage with individuals in different cultural groups, it's important to know their community. I remember way back in nursing school, we did an assessment where it was called a community assessment. And you went out to the community, you found out, okay, what resources are available within such so much distance. So you want to look at those things to see, because a lot of times as healthcare professionals, we may be advising a client to change a practice and it's not realistic for their community setting. Maybe the resources aren't there. So that's one of the ways that the social determinants of health are linked to healthcare engagements, right? Because we know that it's very easy to judge a client for being obese or for not filling a prescription that they were given, but you have to understand what's behind it. Home visiting is such a valuable resource because of that, right? Because if I was just caring for a person in the hospital, all I know is what I know from those days that they're hospitalized, which have become shorter and shorter, right? People that used to be in the hospital for a week are now hospitalized only for a day or two. Open heart surgeries go home in 2 to 3 days now, which it used to be a 2-week stay for that. So things have changed a lot. So community home visiting is so important. I keep saying nursing because that's my profession, but the content is discussed, inclusive of everyone. But when you think about that, home visitors get to go out to the home. So you have way more information than a hospital nurse would have. You just do. You know what the home looks like. You know who's in the home, the individuals that are in the home, and some information about them, right? You know the community. You know how far they have to go to get to a store. I don't think I ever understood what rural truly was until I traveled to Oklahoma. And I saw like there were some areas that I went in where you had to travel an hour or so just to get to like a restaurant or a fast food place or a gas station. So when you think about that and you're telling a client, well, why aren't you keeping your prenatal visits? Well, it's not as easy as you think. Maybe they don't have transportation. Maybe transportation services don't go out into that area. And we also know, and I don't know how it is in Canada, but in America, what's happening is that more and more resources are being pulled from rural areas. And so when you're pulling those things away, then what ends up happening is you have less resources for the individuals that you're caring for. So again, we can judge it, but we have to understand it, right? It's unfair to judge it. We should approach it with curiosity. I want to understand why you're not filling your prescription. I want to understand why you're not keeping your visits. That's culturally sensitive, is to be able to do that. So community involvement, engagement was one. Another one is policy advocacy. We know that data collection strategies or things that, I want to go back. Data collection is another one as it relates to social determinants of health. We know historically, a lot of the scientific studies were done on Anglo men. And so women and minorities weren't really included in some of those basic studies that were done that then advised clinical practice. A lot of those trends are now changing, and they're including other demographics into clinical studies. So we're getting better or different information. And then going to policy advocacy. We want to advocate for policies that address systemic issues that contribute to health inequities. Again, going back to that same scenario. And you can ask questions, well, like as far as employment, like if there's a cultural group and their unemployment rate is very high, let's not judge them being unemployed. Let's instead take a step back and approach it with compassion and say, I wonder what the historical trends are that led to such a high unemployment rate. And some of those are policies that, were set way back when to repress or oppress individuals or populations of people. So that's reality. That's what we know based on evidence. You can't argue that existed or that those systemic structures still exist today. But and so as nurses, we can also influence policy. And then another one was trauma-informed care, being aware of, recognize and address historical trauma experienced by Indigenous and Black individuals. Next is patient-centered approach or client-centered principles, right? Or patient-centered approach. Prioritize the patient. Understand that, just like the slide we looked at earlier about the salad bowl, everyone is an individual. So just because I ascribe to a certain cultural group doesn't mean that everything that's the general thing about that cultural group that I have adopted and I practice. And so you go with it informed with the information, but without the assumptions, right? You're going in to interact with the client and assess to see if those things are true, to get verification through your assessment and through your interactions or engagements that information is valid for this person. And you do that and there are two big things that you'll hear me say throughout this presentation because they're life lessons for me. And one is we should be always approaching with curiosity, and we should always be assuming positive intent. Those are two key components of delivering health care that's equal or to promote health equity. We want to make sure that we are approaching with curiosity and assuming positive intent. And what that means is that assuming positive intent means that I know that the individual wants what's best for themselves, right? That's assuming positive intent. I'm not approaching the individual with maybe some stereotypes that I've formed based on, what I've heard or what I've been taught over the years. Instead, I'm approaching them as an individual and assuming positive intent, assuming positive about them, that they want what's best. And then approaching with curiosity. We're never going to know everything, especially about cultural groups. We're not going to understand if you've not grown in that environment and you've not had their lived experience. There's only so much that a book or presentation can teach you. The rest you find out from the family by engaging with them and asking questions to understand. And sometimes along the way, there are missteps. We make missteps all the time. There's one I made that probably changed totally of that component, but I went in one day to do a discharge on a postpartum client that I hadn't cared for. Another nurse had asked me to go and do a discharge teaching. And I go in to do the discharge teaching, and in my discussion, I am referencing the baby, and I say, and I refer to the baby as African American. And she was a black individual. She had a fit and was so highly offended that I referred to her as African American because she didn't descend from Africa, or she didn't adopt to that terminology. And to be honest, when I left the situation, I still didn't understand why she was so offended, because I thought those terms were used interchangeably: African American Black, Afro-Canadian Black. I thought they were used interchangeably, and that was a learning experience for me. And discussing it with my brother later, he said, well, I totally understand why she felt the way she felt and why she felt so strongly. And he explained it to me from his perspective. And that has forever changed how I introduce that. So now what I do, what you'll see in what I write, what I speak, is usually I refer to the terms together. And I'll say African American and or Black. I don't assume that anyone is from, or in Canada, it would be Afro-Canadian or Black. So you want to do those things. And that shows what, once you hear it, we'll make mistakes, but once it's corrected by the patient or the family, then you don't do it again. And that's regardless of whether it's gender. If it's gender and the person says, I prefer to be referred to as she or they, once the individual informs you, to use the wrong term again is disrespectful. And so you want to make sure that you use the information the family is providing through your inquiry, that you respect what their wishes are. So if I make a misstep and say something that wasn't received quite right, I apologize and I correct it for the next interaction or next encounter. Make sense? So another one is, I think that's most of those. And so let's go to the next slide. So, it talks about, so let's just, before we change, let's talk about equity and inequity. So, and most of you have probably seen a diagram where they show like three individuals and they're showing them trying to look at a football game, right? And they're different heights. So just imagine you have a 5-year-old, you have a 16-year-old, and you have an adult. The adult is 6 feet tall, the teen is 5 feet tall, and the toddler or the school-age child is 3 feet tall. If I put them at a high fence, they're all at the high fence, then that would be what? They're equal, they're all at the fence to watch the game, but some can't watch it because they have to climb higher. They need to be higher to be able to see above. So providing a stepping stone or a stair to the individuals who are shorter would then allow them, and the appropriate height for what the need is, right? Then that would make them equitable. Does that make sense? And so it's the same with health equity. We can, as some of the situations I've described have been about, us seeing individuals who have health conditions, and if we've adopted stereotypes for that, you're looking at that and to make things equal, like let's talk about resources, like if we're discussing diet with a family, right? And we're telling them healthy foods to eat. And if we're judging that by our environment in our community, there are grocery stores, there are fruit and vegetable markets that I can go to that are very inexpensive, and those resources are available in my community. I can't adopt what I see in my community to what's available in the client's community. That's why the community assessment, family assessment is important, right? I need to know what resources they have to meet whatever I'm telling them is important, an important change for their health. And so I want to know, like, what resources do you have available? And is it realistic to be able to get them? Like some communities don't have grocery stores, they have fresh fruit. They have very limited grocery supplies. Another thing is that fruit and vegetables digest quicker, right? And when they do that, that means you need to eat again and again. because you eat more frequently when you're on a high fruit and vegetable diet compared to if you're having meat and carbs that may last a little bit longer. So where it may seem like the cost is similar, one, the cost in that community for vegetables and fruit may be more expensive than what you're seeing in your community. And by that same token, the frequency of needing to eat may be a resource issue as well. So again, just being culturally sensitive and understanding how that can impact what the client has access to. So equity would be providing the resource at the same cost and availability that it is in another community. Or if you can't bring it to that community, what do you want to do? You want to find a way to get that individual to the commodity that they need. Home visitors do that a lot, right? They have resource lists and they say, okay, client has this need. Here are some organizations that can meet that need. And so home visitors are critical in connecting families to resources to help eliminate some of the things that cause the health disparity. So that's real important to just reflect on for a bit. Okay, then looking at, so I want to make sure that we focus in on the two populations that have the most prevalent discrimination or inequity, health inequity in Canada and in America. And that would be the Indigenous Canadians and Americans, Black and or Afro-Canadians or Americans as well. And so when I look at some of the generalizations for instance, for Indigenous, first of all, let's just think about some of the historical context, specifically to Canada, but also some of the same things that happened in America as well. And some of those historical things, one of the ones that's most profound in Canada is that there was a goal at one time to have everyone assimilate. So Indigenous people or children were placed into schools that and there were laws that kept them from speaking their language or employing their practices. And so there was an initiative that was designed to cancel out the culture. Okay, and you all know that history of that. And then the entity where those children were brought, there was also some abuse that happened in that entity. So that historical context is important to understand why individuals may be hesitant or distrusting of health systems or school systems, right? We need to know the history of where a cultural group has been to understand what's advising their present. Similarly, with Black or Afro-Canadians and Americans, what you see in that situation is quite similar. You know, they were abused as a result of slavery. And we're talking physical and sexual abuse for both groups. And so as a result of that, those are real things that happen that can be tracked in history and proven, right? And so we don't water it down or act like it didn't happen. We embrace the fact that it happened and then move on and figure out ways that we can understand the cultural group better, right? And embrace might have not been the best word, but we have the knowledge of. So that's the history behind both, right? We also know that in Canada that, and I learned this in preparation for this presentation. I had no idea that this was true. We know that there were slaves that were brought to Canada, but we also know that the Underground Railroad, Canada was a destination for the Underground Railroad. So that was new knowledge for me in preparation for this. And I would say that probably a lot of African-Americans African-American Black individuals do not know that. And so that's how you ended up with a population of Afro-Canadians and Afro-Americans, right? And then once they migrated over, they weren't always treated the best, right? Some were allowed to be free, others were enslaved in Canada. And so those things are what are still today influencing how people engage with systems, right? And then even once there was an emancipation, there were still structures put in place to keep individuals from becoming successful. And then there were even situations in America where individuals were able to become successful, and those structures of success, like communities, were totally destroyed to prevent them from rising. I once heard a story, and this is a really good story because it kind of makes you understand this concept a bit more. But it was where an individual kept some fleas in a jar. You know how when you were little, you might have caught bees and put them in a jar, put some holes in the top. Well, they put fleas in there. We know that fleas can jump pretty high. In case you all don't know, they can jump like 3 football fields. That's how high they typically can jump. Well, they were kept in this jar for so long that they learned to only go to the top of the lid. That's as far as they could jump, to the top of the lid. So when the individual took the lid off the jar, the fleas stayed in the jar. They never jumped above the lid. And so that kind of explains it. When you're oppressed for so long, you don't know that success is possible. And so it does impact all the things that influence care, education, engagement with employment, like being able to be employed. All of that is influenced if it's not seen as valuable, or it's not seen as achievable, or it wasn't, and by valuable, I mean, wasn't valued in the community because there weren't a lot of people that role modeled it, then it becomes the norm. And so our goal is to support that as well, to support individuals being able to find or reflect on their life experiences and set goals to improve where they're at, or to change their outcome, right? So those are some of our goals that we have. So keeping in mind of time here. And so, and then there are also, so some generalizations of Indigenous are that, we know that one of the health disparities is that alcohol or substance abuse is very prevalent in that community. I don't then take that generalization. I know that that's a prevalent health problem, and that's what it is, a health problem, right? I don't then take that and turn it into a stereotype. The difference between a generalization and a stereotype is this. A generalization is what I learn about a cultural group to advise my practice, like I described earlier. A stereotype is when I take that generalization and I apply it to every single individual in that cultural racial group. Then it becomes a stereotype because I'm now weaponizing it. I'm using it as a weapon against the individual rather than using the information to support the individual. So big difference. So we're assigned to know the generalizations, and then to not only know if I'm stereotyping someone myself, but also to be able to recognize it and correct it if we see it in others. If we see an individual, like a colleague who's saying a certain thing about a cultural group, well, like referring to them as lazy or not wanting to work, those type of things, then we got to go back and think about the history. What led them here? What's keeping them from getting where they need to be? And so looking at it with more compassion, our job is really important. It's crucial, right? If we're going to really realize and really change our racial relationships in America and Canada, it's going to take compassion. It's going to take real action, not just putting a Band-Aid on it, but real changes in practice and how we interact. And just to give you some ideas of how people are impacted in healthcare. For example, I remember, like, I'm an L&D nurse, labor and delivery nurse. And one of the things that I noticed when I was practicing actively, I'm working a little labor and delivery now, actually. But when an individual, the guidelines would say that if someone presented in preterm labor, then it was customary for you to do a urine drug screen and a urinalysis, because you want infection predisposes to preterm labor, and so does drug abuse, right? Both of those predispose. So those were things that you wanted to do for all individuals who presented. What I started noticing in practice was that if a Black individual came in preterm labor, both tests were done. If a white individual came in labor, they only did the urinalysis, they didn't do the drug screen. And that's why racism hurts on both sides of the equation, right? because what it does to the person that you didn't send the drug screen to, you didn't have all the information you needed. What if that drug screen would have been positive? You won't be prepared for the baby that may come out addicted, right? Or you won't be aware of some of the predispositions that that mom may have in labor or during delivery. And so racism hurts both sides of the equation, not just one. And it also makes it so that what would make a person assess one person, if the standard is this, what makes you interact differently with the two different racial groups? And that's what we're talking about. So we see it in practice. It's not talked about a lot, right? But we also see it in the outcomes. We see it in the outcomes. We see increased risk of maternal mortality. Maternal mortality in the state that I live in is like, I think it's 60% higher in African-American women. So in pretty significant in Canada. And I know historically, Canada didn't always collect data that divided the data into racial entities. And now they're doing a better job at doing that. So it's going to be interesting to see more of those studies to see what those differences are that help to change our practice. Same thing, another, that's just one example of how that translates into practice. If we have those, and some of those, and we're not going to say that some of those are overt racism, right? Others, it's you don't even know you're doing it. You don't recognize, but it's the same kind of thinking that causes us, like when an individual walks into a school with a gun, open like a machine gun, right? They walk in, and if they're Caucasian, nobody really takes notice. But if it's a Black individual, arms are up, right? Ready. So it makes us more trusting of some individuals and less trusting of others, sometimes unfairly. And so it hurts all sides of the equation. Another example that I see in the media a lot, and this happened recently, where there was a Caucasian female who had sexually abused a teenage boy. The teenage boy was Black. And when the article was put in the paper, they sexualized the Black male and said he was having sex with the teacher. Same story reversed, white female and Black male, and then he's the perpetrator. But the stories displayed, in the one case, the Black male was presented as almost a victim. How they put it was that he had an affair with his teacher. That's how it was written in the paper. He had an affair. He's 16, the teacher's 35. They're going to her house. He's having an affair with this teacher, because the teacher was married. In the other situation, it's abuse. And so those are trends that just pay attention to the media and how stories are told. All of that influences everything we do. It's what makes a person hold their purse a little bit tighter or be more cautious in certain environments around certain cultural groups. All those things influence healthcare as well. And so just looking at some, like the predispositions for, you want to know, like with Indigenous Canadians, what are some of their health prevalence? What are they prevalent for? And a lot of that is linked to alcohol abuse, like cancer is one of them, substance abuse, not just alcohol, but substance abuse, and cardiac and diabetes. And then with Black individuals, the things are the same, right? It's hypertension and diabetes are the top, or heart disease and diabetes are prevalent in Black or Afro-Canadians as well. And so looking at those things and knowing that and using it to inform your practice. And then, so I want to move into a few case studies. And so let me get to that part here. And this is just to kind of depict, I wish this was more interactional and we could actually do it. I've used it before, and we use it to just kind of dialogue around what was happening. And so we do have the chat open, I think, for the case studies. And so you can put some of your information in there, and then we can read those out. But we want to go to case study 1. Okay, so here's the case study. A Black woman in labor is on Pitocin. She's received an epidural, but she's still in pain. The registered nurse calls anesthesia for evaluation. The anesthesiologist enters the room, and just imagine a football coach, a very angry football coach talking to his players. That's how this provider walked into the room to address this client's or patient's concern about her pain. And he walks in and he says, "It's no way you're feeling that. I've given you so much medicine," meaning through her epidural catheter. And he's yelling at her and screaming in a very loud voice. So the nurse then looks at him and says, "You can't talk to her like that. She's a nurse. She's a registered nurse. She's a labor and delivery nurse." And so immediately when the nurse shared the fact that the patient was a nurse, because the provider had assumed because she was Black, she was a Medicaid patient, right? Guess what though? Does that matter? Does it matter that she was a Medicaid patient or private pay? But the minute the nurse affirmed that she was a professional, his behavior and interactions changed. He changed in that moment and started being kinder. He then sits the patient up to do her epidural, and in the bed, about the size of a large plate, is a puddle of fluid. Her epidural catheter had come out of her back, and he had been dosing the bed. So just thinking about that situation, and you can put in the chat, what are some things that you see about that situation or some recommendation or practice strategies that you would have done if you were the nurse interacting with that family? What are things you would have said? So I'll give you about 10 seconds to put those into the chat. I love that, Irene. I love that. Irene says the nurse didn't need to identify that the client was a nurse. She just needs to say to him, she's human. She's a human being. Why are you treating her like this? Another thing we know about African-American and Black women and Afro-Canadian is that there's been this misconception in history that we don't experience pain or we have a high pain tolerance, right? And it's not a true perception, but it's a perception. And so a lot of times pain medication is withheld, right? And then if you look at the native or indigenous family, a lot of times the assumption is that they're drug seeking because of the history or the knowledge that we have about how prevalent substance abuse is. A lot of times medication will be withheld because of two reasons typically. One is because there's an assumption that their cultural practices influence or dissuade the use of pain medication. Another is because an assumption is made from a stereotype, right? So stereotypes influence health interactions because they cause you to withhold things or do things that can actually cause trauma to the family. And so in that case, they're making an assumption that she doesn't need the pain medicine that she has. And so I love some of the things that are coming in, apologizing for the pain that the patient is feeling and assess the patient to see if something is wrong. Like it could have been so many other things other than the catheter sliding out of the back. And it was so interesting because in that story, what had happened was the healthcare agency had changed their catheters, and the catheters that they were using were more likely to come out even when taped and secured. They were very likely to come out of the back. And there was never an apology to the patient, never an apology to the patient. There was a change in tone and interaction, but there was no, but how important was it for that nurse to advocate for that patient and to not have her have that negative birth experience, right? In home visiting, there are so many ways that you can use that same kind of knowledge. For instance, if you go out to a home and you're caring for a family with a pregnant member, right, who's experiencing pregnancy, and they're telling you, you're seeing that their blood pressure is elevated or other things that you're seeing that are abnormal, or they're saying the baby's not moving, and they present it to the emergency room and they were sent home without what you know is standards of practice, right? They're sent home and they're seemingly ignored. Nurses can advocate. There are two ways we can advocate. One is we can teach the client how to advocate for themselves, what things they need to say, help them to write a script and practice communicating with the provider, because providers sometimes can be very intimidating. We can also share these stories with our peers so that they also can know how individuals can be impacted and how health outcomes can be impacted. And I'm loving the comments that are coming in. One person says the nurse identified the client as a nurse. She may have had a history with this doctor. This is her fastest approach to pain management at that time, is to be able to get that. And so it was also important for that individual to read the chart before going into the room. And so holding our peers accountable too, right? Sometimes, like if you're helping the client to make that call and the client is doing all the things that you've provided coaching on, and they're still being ignored, then it's time to do something different, right? And it's so advocacy may involve you actually making a call or you calling out a behavior in a colleague that isn't aligned with what we want to practice. So thank you all for that. And I think we have time for one more. I had 3 prepared. I think we have time for one more. So the next one is a 23-week pregnant Black teenager has attempted suicide and is comatose, and she's hospitalized in the ICU. The ICU nurse is in the room and she sees movement in the sheet. She lifts the sheet up, and here is a baby in the amniotic sac, delivered in the bed, and it's moving around. And so she then tells the provider that the baby has been born. He comes into the room, he sees it. His response to the nurse is, throw it in the trash, it's not viable. How would you respond? Let's put it in the chat. This really happened. It really happened in real life. I love the comment. Somebody said they would say absolutely not. And several others said it's horrific, right? And somebody says we should call NICU for help. We've had a 22-week thriver, right? And then someone put needs to be fired. So what happened in real life is that the nurse ignored what the medical resident was telling her to do, of course. She then called labor and delivery, which happened to be the floor down. And the OB resident ran upstairs, took the baby in the amniotic sac without cutting it open, and ran down the stairs, put it under a warmer. She had already had the nurses turn the warmer on, put it under the warmer, cut the sac open. And 5 years later, on the front page of the paper, that baby's story was told. So, and the baby had no deficits. Isn't that amazing? So, and we know it was a Black female baby, and we know that historically, our generalization that we know is that if you're going to have a premature baby, the ones that survive are most likely to survive are Black female babies, right? So having that generalization lets me know, we can't just make the decision that this baby isn't viable. And so those are the 2 I have. I think now is it time now to break for questions and answers, or do I have more time?
If we could transition to questions, if you have a concluding thought, please share that, and then we can move to questions. Absolutely.
The only thing I'll say is that what we are called to do is such an important task as health professionals. We are called to ensure that we're holding ourselves accountable, holding individuals accountable, and we do that by first recognizing that racism kills, right? Our outcomes show that racial inequality or inequity are influencing outcomes and causing people to die before they are expected to die, right? And so the way that we do that is we really have to get involved. We have to hold our colleagues accountable and call it out when we see it. Or I don't like the word call it out, maybe call it in. Call it in, let's have a discussion. Let's find out why you did this instead of this. Because this is a standard of practice, and I noticed you did that in this situation. So call your colleagues out. And I had a lot of information that I'll provide in a handout, but it's related to motivational interviewing and using motivational interviewing technique to develop discrepancy. Like when an individual doesn't believe that racism exists, using those tools of motivational interviewing and reflective practice to engage in those critical conversations to re-educate first and reaffirm, yes, this is why this is happening, right? So it is related to racism. And then when they don't receive it, sometimes you got to roll with the resistance, right? So looking at those MI strategies to use those to guide your interactions with either community individuals or with providers.
Gosh, great. And Melinda, thank you. Many of our, many individuals who are participating today use MI in their practice. And I know everyone heard the word handout, and we will be working with Melinda to develop it as a practice guidance resource. And so keep checking back to the PHN Prep website over the next month or so, and then it'll be posted. So I have two questions, and just in our last couple of minutes. Melinda, are you aware, or do you happen to know if there are differences in health outcomes for racialized groups based on whether they're born in the country, so born in Canada or US, or have recently immigrated?
That's interesting, because what studies show is that individuals who have assimilated aren't always treated the same. Like for instance, and I'm just going to use Hispanic individuals as an example. There are Hispanic individuals who are assimilated to American culture or Canadian culture where you can't really tell that that was their origin. And so that's interesting because they're not treated the same. And however, the data is not divided. Like if an individual only speaks their native language, right, compared to being bilingual or speaking primarily English, then those individuals are treated or engaged with differently in health settings. But however, the data is not separated to say this person's more assimilated than this person. So they're all included in that data. So if we were able to divide that in some type of a way, which I don't even know that is possible, then you probably would see differences. Another interesting fact as it relates to Canada is that when you look at African-American women in America and disparity, what you see is that regardless of your income status, Black women are treated the same when they engage in, treated poorly, but the same in health engagements. In Canada, for some reason, Black individuals that are more wealthy or have greater means are the ones that that experience racism the most. And that was very interesting for me in reading that. Does that answer your question?
It does. And just, and even it's been a while since I've looked at this literature, but the last time I looked at some of the literature, because I think it, a response to this question, it often depends on outcome. But that related to the outcome of preterm delivery or preterm birth, that there was some protective effect among recent immigrants to Canada, that the rates, there was a virtual absence of preterm births in comparison to other groups. However, the longer that individuals were within, the longer that immigrants were within Canada at the time of birth, they started to see more rates of preterm delivery and low birth rate, and really link that to the neighborhood or community effect based on socioeconomic disadvantage. So I think it then speaks to the need, again, as you mentioned earlier, about collecting data on race and on ethnicity, and starting to look at, what is occurring with respect to experiences of racism, discrimination within communities. And then just one last question before we end. Do you have one quick tip for nurses on how to address microaggressions by clients, specifically in home visiting?
That's really interesting, Susan. And just to speak a little while on what you said earlier about, that's also seen in life expectancy. You see that the longer someone's in a foreign land, right, or a new land, their life expectancy decreases. And that's true for Indigenous as well as for Black and Afro Americans and Canadians. So that's interesting. And so your question was, one more time.
Yeah, just do you have one tip for nurses on how to address microaggressions by clients, specifically in home visiting? And I'm wondering if the question is if the nurse home visitor herself may be racialized or Black and experiences a microaggression from a client.
And I've had to support teams that have experienced that, where either it's a client that doesn't want a nurse from a certain racial or ethnic group. In addressing that, you then as a supervisor, you're advocating for the nurse to have the experience, right? And the two things I shared earlier are always your go-to things to do. Approach it with curiosity and then assume positive intent. Those are the key things. And I've had that situation where a colleague may have said a specific thing to another nurse, and then you, by unpacking it, you learn so much. That's the purpose of approaching from curiosity. You learn, you get more information to make you understand what's really going on or what the drivers are behind the action. So just taking a step back, assuming positive intent. Maybe they were offensive, but did they mean to be? And sometimes they would have meant to be, right? That's just the reality of the world we're living in. But other times it's not intentional. It's just normally something they say. And when you look at microaggressions, everybody should look at a list of microaggressions for different racial groups. It will let you'll look at it. I've looked at it and I said, I've said that. I've said that. I say that all the time. When you look at the list of microaggressions and see the root of what the person thinks when you ask it or say it, it helps you to know why it's so offensive. Like one for me is that I don't see color. When a person says to me, I don't see color or we're all the same, what that says to me is assimilation. It says, I like my brown skin. I love my brown skin. I want you to see my brown skin. I don't want my brown skin to be ignored. And so I'm embracing my culture. I want you to too. I want you to see value in who I am, all of who I am. So I think that's where we have to be. We have to be open to having those difficult conversations, even when they irritate us, make us angry. Sit with those feelings and unpack them. And sometimes take a step away and come back and then
Oh
have
my
that.
gosh. Oh, Melinda, I'm already thinking for the handout, let's add this topic as well, like those 2 points you had around approaching with curiosity and the list of microaggressions. Let's add this to the handout. Now, I know people have to leave. And so Melinda, I just want to say thank you so much. I mean, today, is such an important part of our work in helping many of us move from that fear zone to the learning zone. And what you've shared has given us time this morning to reflect and think and to continue all of our journeys towards that growth zone in our anti-racism work. So thank you for sharing. And your examples were such powerful examples grounded in practice. So thank you for that. And as we wrap up today's webinar, I also want to thank Dr. Sarah Carsley for moderating with me. Thank you to everyone who's joined. Those of you who are still on, you're going to get a survey. Please complete today's survey so that we continue to improve our programming to meet your needs. And as a reminder to everyone, save the date for the Ontario Public Health Convention, which will be held in 2024. And the registration will open up soon for our next PHN prep webinar, which will be on December 6th. And our guest experts will be coming to share information with all of us on working with neurodivergent families in a strength-based approach. So I wish everyone a good day. And Melinda, thank you so much for joining us today. Take care, everyone. Goodbye.
Bye, you all.